All right. Thank you, everybody, for coming to the oral presentations that we're having now. We have Dr. Kaavya first that's going to be speaking. We're going to have you use the mic so that the recording can pick up your voice. Thank you.
Hi, everyone. My name is Kaavya. I'm a neurologist. I practice mainly in SGH, but also in Sengkang. I'm here today to share a little bit of work that we've done about treatment of stroke, minor stroke and TIA. So to give everyone a little bit of a background, 1 in 4 Singaporeans will have a stroke in their lifetime. And these strokes usually are ischemic strokes where there's a small clot blocking a blood vessel in the brain. And once you've had a stroke, we give you blood thinners to prevent you from having another one. When we do give the blood thinners, the type of stroke you've had actually influences both the number of blood thinners we give you as well as the duration of blood thinners we give you. So based on several different trials, we give either dual antiplatelet therapy, which means 2 blood thinners, or we give single antiplatelet therapy, which is 1 blood thinner. And depending on the subtypes, the duration of dual antiplatelet therapy may be different. So for small vessel disease strokes and TIAs, which are warning strokes, we give 3 weeks of dual antiplatelet therapy, followed by lifelong single antiplatelet therapy. For large vessel strokes, we give 3 months of dual antiplatelet therapy. And if you have a stroke that's coming from a heart issue, either atrial fibrillation or a clot in the heart, then we give you anticoagulation instead. There is a subgroup of other causes which are less common, so we'll ignore those for now. So if I'm talking about proportion of patients that we see who have strokes which have the different subtypes, it actually means that 70% of all my stroke patients will have dual antiplatelet therapy for a duration of time, whether that's 3 weeks or 3 months or off-label, even longer. And then the next question then becomes, what antiplatelet do I give? Okay, and so these are actually the commercially available antiplatelet drugs. And if I'm going to be giving antiplatelet therapy, especially dual antiplatelet therapy, what I like to give is 2 different drugs that work in 2 different mechanisms. So you can block the blood from clotting in 2 different ways. It looks like I have a lot of options on this picture. But once I tell you that certain drugs are only IV formulations, and certain drugs are very poorly tolerated in Singapore, we're left with very few options that we can combine to give dual antiplatelet therapy for a period of time. Now, I think you heard earlier today that clopidogrel is also a prodrug, so it's not in its active form. It needs to be broken down to its active form. And the option for stroke that's available that's not doesn't need so much breaking down is ticagrelor. But the price for a patient a day is $4 for ticagrelor and about 20 cents for clopidogrel. So we really wanted to figure out what I do when a patient comes to me having a stroke. What should I do, especially with the 50% who have small vessel strokes or minor strokes in TIA that require 3 weeks of dual antiplatelet therapy. I think the background to this is the CYP2C19 prevalence is very high. You heard earlier that it was 50% in Thailand, but it's actually closer to 65% in Singapore. And that varies a little bit based on ethnicity, but actually across the board, about 60 to 65% based on your ethnicity of Singaporeans are resistant to the drugs. We call you as having an intermediate metabolizer status if you have 1 loss of function allele, and a poor metabolizer if you have 2 loss of function alleles. And so I guess the clinical question for us, what should I do with a patient sitting in front of me who's just had a stroke? Should I start dual antiplatelet therapy, and what should I start? So for discussing that, I think I need to take a step back and explain a little bit about the concept of cost effectiveness, because I wasn't familiar with it myself about 5 years ago. It's just looking at the cost of treatment strategy A versus treatment strategy B. And the costs are both direct costs, like cost of genotyping someone, cost of the medications, also as indirect costs, like what's the cost of having a recurrent stroke? And what's the probability of that happening on the 2 different treatment strategies? So we collate all these costs together and look at the costs of each treatment strategy and the difference between them, and also the quality adjusted life years that are gained by doing a new treatment strategy. And looking at this incremental cost effectiveness ratio, which is the difference of the cost on top of the difference of the quality adjusted life years loss, then we come up with the incremental cost effectiveness ratio. And there's no one standard way of saying something is cost effective. Usually you compare it to the country's own GDP to try to figure out whether that particular treatment strategy is more cost effective in your country. So the way we sort of do it is we do hypothetical modeling. In our case, we modeled a 65-year-old stroke patient, and we tried to figure out what the cost would be if I modeled their life until the age of 85. And you do things like you look at the prevalence of the loss of function alleles, you look at the likelihood of you having a stroke if you had a loss of function allele and you were given clopidogrel without being tested. And what's the cost of ticagrelor, what's the cost of clopidogrel, and you put those all into a model. You also vary the costs by plus minus 30% to see what's also driving the cost effectiveness. Okay? Now, we've done it in the past for a single antiplatelet model. So for long-term therapy, we've done it already. And what we've showed is, on average, about a genotype-guided therapy would cost you about 9,000 more per patient, but it will also save you about 0.27 of quality-adjusted life years. And if you look at the cost per quality, which is the incremental cost-effectiveness ratio, is about 33 to 34,000. And given that Singapore's GDP is about 80,000, that's fairly cost-effective. So in this case, for minor strokes and TIAs, where we're talking about dual antiplatelet therapy, what we did is we looked at 3 different types of models. The first model, my stroke patient in front of me, I give him aspirin clopidogrel for 21 days and then continue with aspirin lifelong. The second model is I give aspirin and ticagrelor for 21 days and I continue with the aspirin lifelong. And the third model is I do genetic testing, and only those with loss of function alleles would get ticagrelor, but everyone else would get clopidogrel. And these were the 3 different models we were discussing. Now, this is a little bit of a busy slide, but I will focus your attention on the part that shows incremental. And what you see is if I were to give everyone ticagrelor and aspirin instead of clopidogrel and aspirin, which is the A versus base, the additional cost is actually $58 per year, but you save 0.0034 qualies, which actually turns out to be about a cost per quality of about $16,000, which is very, very cost effective. If I were to look at B versus base, B is genotype-guided therapy versus giving everyone aspirin and clopidogrel, what you find is it costs about $150 more per year, but it actually also saves quality-adjusted life years. And now the cost per quality becomes about $50,000, which is still very cost-effective, okay? But then if you're comparing empirically giving everyone aspirin and ticagrelor versus doing genotype-guided testing, then you find that actually giving everyone ticagrelor and aspirin makes the most sense. And we scratched our heads here for a while because we were like, we know CYP2C19 is probably a good thing to do. Why are we not getting the answer that we thought we were going to get? And we thought, is this because in our particular population, we have a 65% prevalence of loss of function? And so we then did, again, another busy slide, where your x-axis is now the prevalence of loss of function alleles across, ranging from 0 to 100. Your y-axis is the incremental cost-effectiveness ratio, and I've put a dotted line at about 80,000, which is about 80% of our GDP. If you were being strict, that's the criteria you want to hit to make sure someone's going to be or a treatment strategy is going to be cost-effective. And if you look at the orange line, the orange one is very clearly always below the dotted line. And the orange line is comparing genotype-guided therapy versus giving everyone aspirin and ticagrelor. So actually, aspirin and ticagrelor, regardless of your loss of function prevalence, is actually probably the most cost-effective strategy. And then we're looking at the purple line, and the purple line is giving everyone aspirin and ticagrelor versus giving everyone aspirin and clopidogrel. And again, it looks for, other than about 1 to 2% prevalence of loss of function, the purple line is also all below the dotted line. So it's the most cost-effective strategy. Now the green line is a little bit more confusing. So the green line looks at, should I be giving genotype-guided therapy or should I be giving everyone aspirin and clopidogrel? And it turns out that at an inflection point of about 50% of loss of function, it makes more sense for you to do genotype-guided therapy. So if the prevalence of the loss of function alleles in the population is less than 50%, then it actually makes more sense for you to give clopidogrel and aspirin to everyone, okay? And again, after looking at this, we're like, okay, so maybe I don't really have to do my CYP2C19. Why did I spend years trying to get it developed, right? But then actually, this makes my life easier as a clinician, because when I order the CYP2C19 test, it takes 3 days to come back, right? Now I have data that now suggests that I should be giving aspirin and ticagrelor to everyone. It doesn't stop me from ordering the test, but it doesn't change my immediate management of the patient. And it's cost effective for me to do it for at least a 21-day or 3-week window of dual antiplatelet therapy. What I did, which is not exactly correct scientifically, is I tried to see at what point does the data make more sense to do genome-guided therapy. And the answer unofficially is 90 days. So the minute that you're crossing the 90-day window of giving dual antiplatelet therapy, it makes more sense for you to do CYP2C19 testing. And the reason for that is that the cost difference between ticagrelor being $4 a day versus 20 cents a day, it adds up the longer you have to give the ticagrelor for. So that's the rough takeaway I have from this study, so that I also know that when I'm planning long-term clopidogrel or long-term ticagrelor, I would want to know. So it works for the preemptive and it works for reactive for the long term. But for a 3-week window, I'm actually perfectly fine getting away with Empiric, ticagrelor, and aspirin. And so that's the main takeaway from the study. But I will also say that pleiotropy is a thing, so CYP2C19 also affects other drugs. So I don't think it's necessarily a one-to-one comparison. Yeah? So that's about it for me. Any questions?
Yes, so how would this kind of be implemented into practice? Like, would it be via QIP or audit?
So since the Chance2 trial came out in 2022, I think everyone has been ordering CYP2C19 therapy. And I think what happened before the study is people were still giving aspirin and clopidogrel and waiting for the CYP2C19 results to come out and change the drugs after. What has now happened is actually, as a result of the studies, we give ticagrelor and aspirin instead. We still send a CYP2C19, but then we make that decision at discharge about whether we want to change our longer-term plans. Because actually, overall, for prevention of stroke, Plavix, clopidogrel is slightly better than aspirin, so it may now change my choice of the single antiplatelet therapy that I give in the long term after the 21 days.
Okay, thank you so much, Dr. Kaavya. All right, you all, we have our next presenter, Dr. Janice Goh, that will be going next. Thank you.
Okay, hi, thanks. Hi, I'm Janice, and I'm from the Bioinformatics Institute at A*STAR. And so this is quite exciting. I am a pharmacometrician, or more commonly, people will know this as pharmacologist who does math. Okay, and what we're presenting today is how can we use pharmacology with math to be able to help us to guide our drug-gene interactions. And for this pilot study, we're focusing on chemotherapy, because chemotherapies tend to have one of the narrowest therapeutic windows. Okay, so, all right. So I think by now, if you have attended enough of the conference, I think this figure has actually appeared before, that Asian genomes are understudied. And so we actually need better characterization of our own genomes to be able to then handle our medicines well. All right, so with a lot of pharmacogenomic guidance, generally we just think about the drug and the gene. And then after that, we think about how this impacts the toxicity or the drug's lack of efficacy. However, one thing I think that is not being well looked into is actually how drug exposure impacts this, of which drug exposure is usually a huge driver of either your efficacy or toxicity. But we haven't really always talked about what impact this actually plays. And more importantly, drug exposure is not only affected by the gene, but for many years we have actually known, and the pharmacists have been adjusting your drug dose for things like other factors like your renal function, your age, and your weight. So this is where, and what we see is that in the CPIC database, which is one of the guidances out there for pharmacogenomics, we actually do see that 71 out of 109 of these drug gene interactions where they recommend a clinically actionable practice is actually 71 of them are related to changes in drug exposure and not necessarily drug allergy alone. So in this case, things like our HLA genes, we're not really looking into those because we know that if you're going to develop a serious allergy, no matter the dose, we change the drug. However, for 71 of them, we could actually recommend a dose change instead of having to stop the drug immediately. Okay, and so this is where my expertise comes in. So one of the things is that with CPIC, we do not always have a full, we have not characterized all the drugs well, but in drug regulatory systems, for any drug that goes onto the market, you have to do these things called drug-drug interaction studies. So using small molecule studies, we have already discovered and well characterized a lot of what the major clearance pathways are for any given drug. So utilizing the same database, we can then use it to ask instead like which drug and which genes actually interact in a significant manner. So instead of saying a strong inhibitor causes the drug level to change, we can instead ask if there is a variant in the major clearance pathway instead. So just by using this set alone, okay, you can see that if you have a variant in the major clearance pathway, you will actually see that your drug exposure should change significantly. However, in this case, if it's a minor pathway, which means that, for example, your gene may interact with the drug, but if it takes up less than 20% of the drug's clearance, we actually may not see any significant difference. So this is one way we can actually prioritize the gene sets. Okay, oops. All right, so this is the way we did the drug gene set prioritization workflow. So using 205 unique drugs from the cancer drug list. So in this case, we're excluding biologics for this study because biologics are cleared by a very different pathway. We're left with 157. After that, what I did was just very simple. I just pulled out the drug-drug interaction database, and then we asked which drugs actually have major metabolism or transport interactions, and we're left with about 76 drugs. And so after that, what I did was I just wanted to ask how common are the variants in our Singapore population? And so using the SG10K genomic database with allele frequency, we can then decide like which are the drug gene sets we should actually prioritize looking at. Okay, so based off this workflow, we highlighted 8 drugs as likely to be impacted by the pharmacogenomic variants in the Singapore population. So as you can see on the left graph here, these are the pathways that are impacted in the cancer drug list, and those are the ones in blue. And so in this case, for things like CYP3A4, even though it's known to be one of the most promiscuous drug metabolizing enzymes, because the good news is that we actually don't have a huge load of variants in our Singapore population, we can be assured that we don't really need to look into CYP3A4 pharmacogenomics. However, for things like CYP2B6 and CYP2D6, these are still extremely important, and so we should look into drugs that are highly impacted by the CYP2D6 and CYP2B6 pathways. Okay, so out of these 8 drugs, now with the figure on the right, I can show you that these are the drug gene sets where the major, these are the major clearance pathways of these drugs that we have highlighted. Okay, and so for just an example for this talk, we're talking about tamoxifen, which is metabolized by both CYP2D6 and CYP3A4. But in this case, because CYP3A4 doesn't have a huge amount of variation, we can focus on just the impact of CYP2D6 alone. Okay, so this is where my pharmacology with math comes in. Okay, and so what we can do is we run this thing called mixed effect models or population pharmacokinetic models to be used to describe the drug exposure. So tamoxifen is actually also a prodrug, and what you need to do is to let it be metabolized by CYP2D6 to be able to form its active metabolite endoxifen. So very often you can actually judge how effective a drug is partially based off its drug exposure. So the higher the level of endoxifen, the more effective the drug is supposed to be. Okay, so using a PopPK model, we can actually simulate the drug exposure profile of tamoxifen and subsequently also its endoxifen metabolite. So depending on the kind of metabolizer status you have, this endoxifen level can change using this mathematical equation. So what I did was that I did 1,000 simulations across Singaporean breast cancer demographics. So things like, I put in things that the median age of a breast cancer patient in Singapore is 56 years old, and the weight range, and then I just decided to do some simulations, okay? So one of the ways of summarizing a whole curve is this metric called the area under the curve, where you just take the integration of the drug exposure over time. This gives us a single value here, and we can see a distribution because of the simulation. So in order to try and evaluate if the pharmacogenomic variant had an effect, what we do is we just compare this AUC of the different metabolizer status against the wild type. And so what you can see here, because current guidelines recommend a 20 milligram flat dose of tamoxifen for everybody, we can actually see very clearly that in this case, the rapid metabolizer does great, as expected. However, with the poor and intermediate metabolizers, we are not hitting this therapeutic threshold at all. So what's great about this model is that we can then input different doses to see if we can actually recover this exposure. So using this simulation alone, we can actually say that a 40 milligram dose of tamoxifen is actually equally useful to be able to push your intermediate metabolizers towards a similar exposure to your wild type. Yeah, but in this case, however, for the poor metabolizers, we actually cannot push it up to the same exposure, and I don't know about the safety profile of anything beyond 40. So in this case, if you're intermediate, we recommend just a double dose, and if you're poor, we still recommend that you have to change therapy. Okay, and so now one of the other conundrums we've always had as Asians is things like, oh, if Asians are lower body weight, does it mean we should still go with a lower dose? So using the model, we can test this as well. Okay, so using this weight range, which is what we would generally expect of your average Singaporean female, which is anywhere between 40 to about 76 kilograms. Okay, we can also model the impact of body weight, and in this case, we can see that through this weight range, the endoxifen levels actually do not change that much. Most of the lines are relatively flat. So in this case, we can actually say that for intermediate metabolizers, the 40 milligram dose still holds regardless of the weight. Yep. So in conclusion, what we did was that we used a list of the cancer drugs, okay, and just by using their metabolizer transporter interactions from a drug-drug interaction database, we can actually reprioritize like which drug gene sets are important. Okay, and we identified 8 that are of clinical importance. And using the population PK modeling, we can then propose new doses and new ways of actually handling these drug-gene interactions. Okay, thank you. Hi, yes. So I do have a collaboration with NCCS, but this has not been directly implemented. This is still something that we just started very recently. Yeah, so I mean, I do hope that eventually we can, but at the moment, a lot of these models used are from literature. Eventually, I do want to do some studies within Singapore itself to validate things and to make sure that this actually works well. But of course, like it would be a good dream to actually have all these dosing algorithms out, such that you can just put in your patient profile, I give you the dose. Yes. Hi, Jane. Yes. Okay, so the first thing we need to do is we need to validate it. Okay, and I would guess the main challenge will also be things like how much good quality data we can get. Yeah. Yeah, I haven't actually thought that far about it because to me, I just really wanted to prioritize it and get the recommendations out first. I haven't thought fully about how to implement it yet, but we'll probably start off with a very small set of drugs first and before we expand from there. Yeah.
Okay, I think that's it. Thank you so much. All right, we have our next presenter, Dr. Eugene. You can go ahead.
Thank you. Not doctor yet. I'm a final year PhD student. So just a sneak peek of what's coming. Yeah, so my presentation today is on statin metabolism, in particular statin lactone metabolism, and how it predicts cardiovascular outcomes up to 5 years into the future. So my presentation will be quite a high-level presentation. A lot of the details I'll skim past. Please feel free to ask me during the question and answer. So the contents, I'll first talk about the context. We'll talk about the trial methodology, our analytical methodology, results, discussion, and finally conclusion. So a context is that statins are a cornerstone of cardiovascular medicine. 200 million people take them in the world. So how they work is they lower LDL, cholesterol, and therefore lowering cardiovascular events. However, like every other drug, statins have off-target effects or side effects. So these side effects attenuate the benefit, and a lot of the mechanisms behind these side effects are unknown. The most common is muscle pain, but that is also a subjective measure, so there's difficulty in researching that. Nevertheless, the cardiovascular benefits of statin usually outweighs the side effects, so it still remains to be one of the most prevalent drugs prescribed. So one possible culprit is statin lactone. So statin can be metabolized in the body, and one way it can be metabolized is lactonization. So there's a group in the Netherlands that did some research, and they found in myoblasts, so this is like in cell culture, that a high amount of statin lactone does inhibit mitochondrial function. So in our trial, one of the major statins that we looked at is atorvastatin. So atorvastatin is, out of all the statins, is the most highly prescribed. This is the metabolism pathway. It's given as the active form, atorvastatin acid. So it's right over here. It can be hydrolyzed. It can also be lactonized. So what we're interested in is this particular pathway here in the middle, the acid to the lactone. So we ran a trial in 2015. So this trial is SAPPHIRE, that's the full name. It's an observational multi-center trial of about 1,000 plus patients across NUH and SGH. Inclusion criteria was patients on 3 months of statin use, and we collected all the samples in 2015. So what we did was we told them to take statins at night, how they normally take statins, and they come into the clinic in the morning where we take their blood. So we use their blood for 2 use. First is LC-MS quantitation, mass spec quantitation of the metabolite in their blood. And the other one was we did a GWAS to see the genetic landscape. In addition, we also collected co-prescription data. So a lot of these patients, they were eating other drugs other than statins, with statins. And finally, we gave a survey of how much muscle pain they felt. They had 2 inputs. One is at enrollment, and the other one is at the first clinic visit. So a caveat is that statin-induced muscle SAMs, statin-induced muscle symptoms, is quite subjective. Of the people who reported muscle pain in the first visit, 93% reported no pain in the second visit. And the other, in the other direction, people who reported pain in the second visit, 70% of them reported no pain in their first visit. So muscle pain is quite subjective. So is there anything that we can do to try to get an objective measure of side effects? So what we did, in 2021, so this was 5 years after the trial, we approached the Ministry of Health. We asked them if they have information on the patients that we recruited back in 2015. And they had MACE data, so stroke, acute myocardial infarction, and all-cause mortality up to 2021. So this provides quite a strong objective measure because nothing is more objective than a cardiovascular event. And the question we want to ask is, can we use the samples in 2015 to predict, to see if they did get an event 5 years later? So for analysis methods and results, I split it into 4 sections: metabolism, genetics, drug-drug interactions, and finally validation via animal model. So in the metabolism investigation, what we did was that we checked the metabolism phenotypes in their blood, specifically how much the level of the metabolites in the morning when they came to the clinic. So the interesting thing here is we did as expected. We saw atorvastatin metabolite, atorvastatin lactone being the most highest in the Cox hazards regression. What we did was we split the population into tertiles of atorvastatin lactone. We found out that people who had high atorvastatin lactone had much worse outcomes compared to the first 2 tertiles. So that's the red line over there. So this was true in the NUH and SGH population as well as the combined population. After correcting for multiple testing, is the only metabolite that is significant in both populations. So the next thing we wanted to confirm was this due to the primary action of the drug, which is lower LDL, or was this due to a secondary action? So we found out that this is independent of LDL and Framingham factors. So what this means is that the effect that the statin lactone seems to be doing on the patient is due to a secondary action. It has nothing to do with the LDL lowering capability of the active acid. So from the metabolism investigation, we established that patients who had overactive lactone production, they experience higher rates of MACE up to 5 years into the future. And this is independent of these factors, so we are confident, or quite confident, that this is due to a secondary mode of action. And the next logical question we can ask is this due to genetics? So we did a GWAS, and then with whichever region that was significant in GWAS, we did a candidate gene analysis. And finally, we compared the influence of these genetic factors versus the environmental factors. So in the GWAS, we observed that UGT1A region, so this is the uridine diphosphate, something, the name is really long, but this region is kind of known in the literature to influence statin lactonization. But the thing is, before all this investigation, statin lactone was thought to be a benign metabolite. It was thought to be inactive. So this is good because at least we see what we expect to see. So then we looked at the SNPs that we managed to take out from the GWAS, and there were 27 SNPs. There was extensive linkage disequilibrium. So what we wanted to do was we pruned the SNPs, and then we interrogate the survival. So we wanted to establish the evidence that polymorphism in certain linkage disequilibrium blocks does affect the lactonization and subsequently affect survival. And what we found on the left, so the green colored numbers here is the linear model of the SNPs with the plasma statin lactone. And on the right, the blue is this Cox hazard ratio. And we can see that these SNPs in block 1, so these are all that survived the wall test. SNPs, if you have a polymorphism in block 1, you have a higher lactonization potential. You also subsequently have a higher rate of MACE. Consequently, in block 6, interestingly, it seems to be a loss of function. So if you have a polymorphism in block 6, you have lower statin lactone, and you also get lower adverse events. And finally, what we did was we compared the genetics versus the environment. The number's a bit small here, but the idea is that we want to see if the genetics increase or decrease the lactone by a small amount, then it doesn't really matter, right? But what we see here is that for every polymorphic allele that you have, so these are the different SNPs, and we compare it to urea, to whether you have diabetes or not, it's about the same order of magnitude compared to them. So we know that the effect of genetic polymorphism is quite large. One more thing that the GWAS regression also took out was omeprazole, so that's a spoiler for the drug-drug interaction that's coming up. So yeah, genetic factors are on the same magnitude influencing statin lactonization. So the last part we did was drug-drug interactions. We looked at all the co-prescriptions that these patients had, because there's a lot of drug-drug interaction that exists with the primary mode of action, which is statin acid. So we asked, now that we see that lactone seems to influence cardiovascular events, is there drug-drug interactions with statin lactone? So here's just a general idea of what are most common co-prescriptions patients took. So aspirin is the most common, omeprazole, bisoprolol, metformin. So why do I highlight omeprazole? Because when we did a differential analysis of all the different co-prescriptions with your statin lactone, we found out that people who ate omeprazole, they are the most significant in having increased atorvastatin lactone. So when we draw the Kaplan-Meier curve, we see that people who eat omeprazole alongside statin, they have a much higher 5-year MACE. And then there's also a known interaction of omeprazole with clopidogrel. So we subset out the patients who took clopidogrel, and the trend still holds true. And also when we control for Framingham factors, that trend still holds true. And just some thoughts is that omeprazole is a proton pump inhibitor. It's a very, very commonly prescribed medication, and there seems to be a novel drug-drug interaction between these two most prevalent drug classes, statins and proton pump inhibitors. So that was quite interesting to us. So finally, we wanted to validate what we saw, because our study is observational, right? So we held an interventional mice model. We had 32 mice. We split them into 4 different groups, and we did something called wire injury. So wire injury is a method of inducing atherosclerosis in the mice, accelerated atherosclerosis. So for the negative control, we just gave them Western diet, and then we induced the wire injury. Positive control, we gave them atorvastatin. Omeprazole arm, we gave them atorvastatin and omeprazole. And one more thing is we looked into lansoprazole, which is another PPI. Yeah. So we have 3 hypotheses. Is that mice taking atorvastatin should have less plaque formation after the wire injury, because atorvastatin helps the mice, right? The next hypothesis is that mice taking omeprazole and atorvastatin, they should have more. And the last thing is that any result with lansoprazole is interesting, because we don't know if this is unique to omeprazole or is this a proton pump inhibitor-wide interaction. So these are just some, let me see, yeah. These are just some representative images. We took 60 sections out of every mice, so we averaged them, but these are just some representative sections. So that arrow over there denotes where the neointimal plaque is. And when we, okay, so first I'll show you the lactonization of the mice. So we took their blood and threw it into the mass spec. And we see that the group, atorvastatin plus omeprazole group, had higher lactone than the atorvastatin group. And the lansoprazole group had even higher than that. So we can see that it seems having an intervention of giving proton pump inhibitor alongside statins increases lactonization significantly. And this is the values of the plaque. And we see that, as expected, saline had the negative control group had the most plaque, because they just got a wire injury and then they were just left to live for the next 2 weeks. The atorvastatin group had the lowest plaque, so that is, to our hypothesis, that's great. What's interesting is the omeprazole group and the lansoprazole group had more plaque than the atorvastatin group. So we can see that eating, having co-prescribed or co-administering a PPI alongside statins seems to make the mice experience more vascular remodeling, and it seems to influence the mice negatively. Finally, that increase in plaque is correlated with the degree of lactonization. So some thoughts is that we validated our observations on humans in the mice model. And this is a novel drug-drug interaction, so this is really interesting to us. And it seems that consuming a proton pump inhibitor alongside a statin attenuates the cardiovascular benefits. So conclusion, we have some clinical evidence of lactone-mediated off-target effects by observational study. And this is independent of LDL and Framingham factors, so it's a secondary mode of action. Has a genetic component to it in the form of UGT1A. Has a novel drug-drug interactions between proton pump inhibitors and statins. And in the view of precision medicine, why is this, how can physicians utilize this information? Is if a physician knows whether, because they have genotyped their patient or any other method, they know that their patient has a high lactonization potential or overactive lactone production, they can either prescribe alternative statins, such as rosuvastatin, which has a much lower chance of being lactonized in the human body, or alternative treatment like PCSK9 inhibitor potentially. Right, so acknowledgements. I would like to thank everybody in my lab and people who have helped me with this project. Thank you. Questions? Yeah. Yes, so that's what this slide here says. Yeah. So what we did was we also took the blood after sacrificing the mice. We took their carotid artery for sectioning, and then we also took their blood for LCMS quantitation. And then here we saw that the lactone of the omeprazole group increased compared to the atorvastatin group. One interesting thing is that the lansoprazole group increased even more, and as far as my own hypothesis, we know that lansoprazole is more bioavailable than omeprazole, but that's the only thing that we could think of. Yeah.
So does lansoprazole also inhibit CYP2C19?
Not sure about that.
Because I think, if I'm not wrong, omeprazole
Yeah.
what you're referring to. So it might be good to check if this is the pathway or if it's actually something else completely.
Yeah, but that's also something we thought, because the action on the acid is quite well known. Is because if you eat like grapefruit juice, right, which is a CYP inhibitor, then this impacts your acid metabolism. But because the lactone seems to influence it through another mode of action, which is the mitochondrial inhibition, we think that it's possible that it is a UGT1A. It's because of UGT1A. And there has been studies on omeprazole being a UGT1A inducer, but they're not very well established. So that's something that we are thinking about. Yeah.
Okay, thank you so much.
Thank you.
Is Dr. Jamaica here, or Jamaica? Okay, that you? Perfect. Sorry. Give me 1 second. Okay. Do you need 2 mics? Okay. Alrighty.
Thank you so much. Actually, I'm not a doctor. I'm a pharmacist. It's okay. So we've heard earlier this morning about the PPGX implementation from Elaine, and this is the economic analysis of that PPGX implementation. So we are presenting today the economic analysis of preemptive pharmacogenomic genetic panel testing versus no testing in a multi-ethnic Asian population. So I'm Jamaican. Actually, there are 2 of us presenting today on behalf of our team, and this is Yara. So,
hello, everybody. Thank you very much. So we are from NUS, and we'd like to thank our colleagues, NUHS and McGill, for this study, as well as NMRC Singapore for providing the research grant to do that. Perfect, thank you. So as I think you've heard quite a number of times today already, pharmacogenomics refers to the study of the effect of genetic variants on drug response. And namely, it aims to improve patient outcomes through selecting the best drug for the patient, determining optimal dosage, and reducing the risk of adverse drug reactions, which will be the focus of today's presentation. Right, so small difference. Currently, what is routinely available in Singapore is reactive PGX testing, which takes some days to weeks, around 2 to 7 days on average, and may result in incremental costs as it is implemented as a single drug gene test. And conversely to that, the preemptive PGX panel testing looks at a panel, so multiple genes, and it does so before the need for pharmacotherapy actually arises, which is illustrated, so the difference is illustrated by the 2 red bubbles that you see here. And this leads us to our research question. So we asked, we wanted to look at the cost effectiveness of a one-time preemptive PGX panel test, which is the intervention, versus no PGX testing in a population of, so a hypothetical cohort of healthy 40-year-old Singaporeans. And the primary outcomes of interest was the incremental cost effectiveness ratio, as you already heard about earlier today, and the quality adjusted life years gained. And we adopted a lifetime horizon. So there are 25 clinically actionable drug gene pairs that were identified by NUHS PGX Preemptive Steering Committee. And these drug gene pairs were then further prioritized for our analysis based on these 2 axes. So one was the clinical criteria, and the other the economic. So in terms of the clinical criteria, we looked for strong and consistent recommendations across PGX guidelines, local prevalence of the gene variant in the Singapore population, and high clinical utility. And in terms of economic criteria, we looked at high drug usage associated with each gene variant, as well as the availability of data to populate our model. what is this? So this is the model we use. Oops, sorry. This is the model we used to help us answer the research question. So at the start, you have the population of this hypothetical cohort that enters the model, and each individual has a risk profile attached to them, which can be high, moderate, or low. Some people get to choose, so get to do the testing, and some do not. We assumed an uptake of 40%. And so if the people who did, so people do the testing, we know exactly their genotype. And so those with moderate and high risk get prescribed the alternative drug once they develop an indication. And in the arm where the test was not performed, we do not know the genotype, hence we assume an average of the different risk profiles. Yeah. And here you see two cycles. So one is the cycle of incidence, where a person may develop an indication during their lifetime for a certain disease associated with the prioritized drug gene pairs. And once they do, they start treatment. And in the treatment cycle, you may or may not develop ADRs. So these are the two nested cycles associated with that. I think that's it, yeah. And so in terms of the data, most of the data was local except for the incidence of ADRs, as well as relative risks and health utilities. And some assumptions related to this was that each drug gene pair was evaluated for a single drug indication. So the longer term consequences were simplified in the model. The panel test was assumed to be 100% accurate. And the probabilities of the different, so the model accommodates different diseases, so we assumed independence between them. And now I hand over to my colleague for results.
Thank you, Ara. So now we go to the results. And the screen keeps on shifting weirdly. So okay, on the left panel of the screen is the flow diagram of the prioritization criteria. Those on the red boxes are the deprioritized drug gene pairs, and those on the green boxes are the ones that met the prioritization criteria. Out of the 10 that met the criteria, we prioritize 4 drug gene pairs for cost-utility analysis. These are DPYD capecitabine, SLCO1B1 simvastatin, HLA-B58 star allopurinol, and CYP2C19 clopidogrel. So we present results of cost-utility analysis in terms of ICER as discussed earlier. And if a panel is evaluated at 140 Singaporean dollars with 4 drug gene pairs in them, our results demonstrates a cost saving of $37,600 and also an added benefit of 9.32 quality adjusted life years. This is a dominant economic position, meaning that the PGX panel is cost saving as well as it improves health outcomes. But one might say that we are evaluating our results based on a very low PGX panel test cost. Earlier, they said that the PGX panel is offered right now at $250, and this incurs an additional cost of $6,000, but it's still cost effective at $680 per quality gain. A further increase at $400 for the panel increased the additional cost needed to implement the test at $66,000, but it's still cost effective at 7,000 SGD per quality gain based on an implicit threshold of $45,000 Singaporean dollars per quality gain. Okay, but how sure can we be of our results? And it keeps on shifting. How sure can we be of our results? So we need to assess how variations in our model inputs might affect our conclusions. So how do we do this? We vary our inputs individually through their confidence intervals. So in the screen, the blue bars are the higher intervals and the gray bars are the lower values. And the longer the bar, it means that our model are most sensitive to these parameters. Okay. So, but how sensitive, right? Does it change our conclusion? Most of the inputs, no. except for the cost of the standard and alternative drugs. Specifically, the higher the incremental cost or the cost difference between the standard and alternative drugs, the less cost-effective the panel results would be. And additionally, if there is a 20% increase of the cost of atorvastatin, our results will actually change in conclusion. But how could we improve? Why am I scared? But what parameters could increase the benefits of the panel? So if we include a gene-drug-gene pair that has higher prevalence and also have a drug with better efficacy of alternative drug and also an increase of ADR averted from the standard drug, the panel would be more cost-effective. So what is our takeaway from our work? So preemptive PGX panel testing is likely cost-effective. So combining the costs and outcomes for these 4 drug gene pairs supports the health and economic benefits of panel testing, particularly when including genes associated with high prevalence of variant alleles. And this framework that we have presented can be adapted to evaluate additional drug gene pairs in the panel and their downstream consequences, because what we saw was that the results was not really sensitive to the price of the panel, but it was sensitive to the long-term use of the drug and also the cost of the drugs. So thank you very much for listening. We were not really interested in the diagnostic accuracy of the panel because mostly the yield was okay. So there was also no data to tell us how sensitive or specific it is. So we just use it as for the base case analysis. But we should something that we could explore if we get more data from our clinical part. It's based on the SG, healthier SG cohort, because they would do screening on a healthy population, and this is something that they're thinking to implement in the healthy cohort of the population.
Do you think there's an argument to be made to test earlier than 40 years old? Would that actually make it even more cost effective rather than earlier?
It depends on the prevalence of the diseases that would be included for the prevalence of the disease that would be included in the panel. Like, yeah. If it increases, it makes sense, but there should be a balance between a prevalence and the cost.
I think this is not something that we have explored yet, so, but it's, yeah, the next steps, I guess.
Our next presenter is Jacob, so he's gonna get set up.
Hi, everyone. Yeah, I'm going to switch the gear. I'm Jacob, a human geneticist and computational biologist from the Graduate Institute of Medical Genomics and Proteomics at National Taiwan University, the other NTU. I would like to thank the Precise and the IHCC conference committee for the opportunity to present my recent effort in analyzing the whole genome sequencing data from the Taiwan Biobank. I know we have the limited time. I will skip this by just saying that people believe that the world's famous, the world's most valuable resource is no longer oil but data. So that is why we heard a lot of different biobanks. But why Taiwan Biobank? The Taiwan Biobank has established a comprehensive nationwide database representing the significant repository of the East Asia demographic. This resource facilitates numerous correlation, translational research domestically and internationally. As we are doing genetic diagnostics for the rare disease patient in Taiwan, we need to utilize the public available data set to prioritize the pathogenic variants from thousands of genetic variants detected by whole exome sequencing and whole genome sequencing. So before the SG10K, we heavily rely on the NOMAD dataset. The release of NOMAD version 4 from more than 800,000 individuals, but it is worth to know that only around 2.6 East Asia samples among 76,000 whole genome sequencing data. So this limited sample size restricts the resolution of the minor allele frequency, especially for the population-specific minor allele frequency. So in Taiwan, Taiwan Biobank provide 1.5 thousand whole genome sequencing data with accessible raw data. So over the past year in my team, we have been reanalyze the whole genome sequencing data using the updating analytic workflow. Here is illustration to show that our internal evaluation suggests that while Taiwanese data is similar to the public East Asia population, but there are some minor population stratification. So this finding is not surprising given the vast population size in the East Asia, and maybe it's just attributed to the sampling bias. But it's underscore the importance of the population-specific database like Taiwan Biobank for the more accurate genetic analysis. So in spite there are so many different limitations. As a computational biologist, at least we can benchmark the analytical workflow to make sure that the data is as accurate as possible. So we utilize the benchmark data set from Genome in the Bottle, HG002, as a positive control to recalibrate the variant quality by the machine learning method VQSR developed by Broad Institute to call all of the SNP and the indel variants. So here is an example. If we regress our cohort minor allele frequency against to the East Asia data set from the NOMAD, it's highly correlates. But if we stratify the variance by the variance quality score, the stringent criteria we use, the higher correlation between these two data sets, suggests that the benchmark and the QC are very important. So therefore, we set a 99.7 as a passing criteria to keep the higher precision without sacrificing that much recall for the downstream analysis. We focus more on the clinical related genetic variants. Then we calculate the number of the novel, globally novel variants within our population, within the cohort, and we found that on average, each Taiwanese harbor around 6,000 globally novel variants. But I think the main reason is due to the lack of Asia population data. So we further analyze the data, focus more on the clinical relevant genetic variants. All of these clinical significant variants have been curated and manually checked by multiple practicing clinicians. Our result identifying 23 small variants on the ACMG secondary finding V3 gene list among the participants. It's indicated that about 1.6% of the people are medically actionable. They are having medically actionable variants within the Taiwanese population. So, and also we found that about 1 in 22 couple are at least at risk of having offspring with at least one pathogenic variant. So this information is crucial for the genetic counseling approach in Taiwan and the family planning. And furthermore, we utilize the whole genome sequencing data to analyze the pharmacogenomic loci. The results suggest that 75% of the Taiwanese individual harbor at least one pharmacogenic selected HLA risk allele, and 13% of the population has at least one high-level CYP risk allele. All of these results have been published early this year, and all detailed variance annotation are available through this website. Please go ahead and check it. By standardizing the analysis, the data from the general population can perfectly serve as a population control for the case control study design. So this approach offers a significant advantage of physician scientists, especially in the hospital. They can pay more attention on their patient and to do better management of their patient cohort without worrying about how do I recruit a control. We have successfully applied this method in our own research by utilizing the Taiwan Biobank data as a population control. We conduct the association analysis, and that lead to discovery of a genetic modifier for a GJB2V37I homozygote, which is the most prevalent condition in Taiwan, the deafness. Among these homozygote patients, we can observe in clinic that there are some variation in the disease severity. So our findings suggest that there is a genetic modifier on the CRYL1 gene, which is the upstream of the GJB2 gene. It can serve as a valuable proxy for the disease prognosis. So this is an example to demonstrate the power of leveraging the population-based data as a control. Also, another story is about the pediatric liver cancer. With the population cohort, we were able to comprehensively analyze our data and dive into the detail. As a leading medical center in Taiwan, we are able to recruit a cohort for a specific rare disease and to establish the clinical genetic testing guideline for that specific medical condition. But whole genome sequencing data has diverse application, and we have established a robust analysis pipeline for the structural variance calling. We benchmark our analysis using the material from the genome in the bottle, again, HG002, to ensure that there's the high quality standards. So here I'm just to show that each structural variance tool has its own pros and cons. And in terms of the type of the structural variance they can detect and the size of the structural variance they can detect given the short-read sequencing data. So our findings suggest that to integrate multiple structural variance calling can achieve better balance between recall and precision. While Dragon performed well for the Illumina data, but our integrated approach yield a comparable result with or without Dragon. So this flexibility is crucial for the lab with different computational resource. Again, by doing this, we can detect around 5.1 carrier rate of alpha thalassemia, which is a significant clinical condition in Taiwan. Last but not least, whole genome sequencing data allow us to analyze the mitochondrial genome. Mitochondrial genome has a different inheritance pattern from the nuclear genome, and it plays collective role in the between the nuclear genome. So our analysis can reveal the composition of the haplogroup in the Taiwanese population, particularly regarding, you can see for the Asian population, we can detect the haplogroup from different branches. We found that some of the individuals were classified as into the R haplogroup, which sometimes it can be classified as a part of the European ancestry, as Nomad's data show that it's basically a mixture. I think the reason is that the resolution of the Asian population is not clear enough. So we believe that increased amount of the data in the Asian population will significantly improve the result, the resolution of this haplogroup analysis. With that, I would like to thank all of the participants in Taiwan Biobank, and I would like to thank all of my collaborators in the National Taiwan University and the National Taiwan University Hospital. It's my great pleasure to work with so many different excellent physicians and scientists. We welcome collaboration from other Asian countries. Thank you.